Uh, Good day and welcome to Sinclair's Educational Rounds. I'm Jim Ellermeyer. I'm a behavioral health therapist today, and today I'm sitting here with two colleagues.
My name is Jill Gross. I'm a PA student from Duquesne University.
My name is Sarah Sweeney. I'm a PA student from St. Francis University.
And I'm grateful that you two ladies joined me today. And today what we're going to do, we're going to be discussing the subject of post-traumatic stress disorder, PTSD, as it's commonly called. There are a lot of misconceptions about what exactly PTSD is, and I'd like you could share a little bit of that with us, Jill.
PTSD, or post-traumatic stress disorder, is sort of a chronic exacerbation of your fight or flight response, which is a normal response to stress, but in PTSD, you're kind of stuck in that fight or flight mode, and it interferes with your daily life.
So when do individuals get subjected? When they get to these type of disorders?
A traumatic stressor needs to be present, so a situation that would be threatening to kill them or someone they love, or it could even be present in a police officer or an emergency responder, someone that sees stuff like that.
So what we're talking about then, Sarah, would be individuals that were a witness to a traumatic event or were an actual participant in that event.
Yes. They have either suffered from war, or they have been victims to things such as rapes or things of that sort. Some may also have histories of other mental illnesses.
Sure, and it's talking about things. It doesn't necessarily have to be war and death and rape. It can be situations like being a victim of or a witness to, let's say, domestic violence, divorce, catastrophic events in your life, such as, let's say, divorce or getting fired from a job. Those things which some people can handle, other folks cannot. So, Jill, what type of symptoms do we look at when we're looking to diagnose someone with PTSD?
There's 4 groups of symptoms. The first is intrusion type symptoms. So they have intrusive thoughts, like involuntary thoughts regarding the event and dreams. And they can't predict when it's going to happen or when it's going to bother them. They have avoidance symptoms, so they don't like to talk about it. They try not to think about it. And then they try to avoid whatever situation that is in general. They have negative mood and cognition alterations, so that could be forgetting parts of it or persistent negative beliefs or emotions. It could be a distorted sense of blame, thinking that they could have done something differently. They just can't feel happy, or they might feel detachment. And then there's also arousal and reactivity symptoms, meaning that they're either hyper-vigilant or they're acting startled when they really shouldn't be. They have sleep disturbances, outbursts, and or difficulty concentrating.
Sure, and Sarah, perhaps you've been around some folks and they have distressing recollections of these things that happen. Night terrors, yes. You happen to ever dealt with anybody that had night terrors?
Yes, and then also their social functioning can be affected, so that whenever something occurs similar to the tragic event, then they can have recollection of it occurring in the past and have flashbacks.
Yes.
Is a major
I
factor.
think, and particularly when folks talk about combat veterans, they talk about these folks having flashbacks. What would you call a flashback, Joe?
Like another name for it?
Yeah, what would be a layman's description of a flashback?
If we were sitting here right now and all of a sudden I forgot where we were and what we were doing because I couldn't stop thinking about something that happened in the past.
And sure, people get either psychological or physiological symptoms from cues. Maybe it was the dog that had bit them. Maybe it mauled them in their life, and maybe they see something and it sets off a cue for them. Being in large groups of people, maybe being in water, being in a swimming pool, maybe someone nearly drowned, maybe someone was bitten by a shark.
Loud noises.
Yes, loud noises. And you're right, Joe. You were talking about avoidance, and some people do that to the point where they become isolated, and they won't leave their house. They stay in the house. They draw their shades. They won't answer their phone. They won't open their mail. And you were talking about disturbed sleep patterns, which we see awful lot. Irritability, hypervigilance. What would you call hypervigilance? What would you say if someone told you they had hypervigilance? What would that be?
That's sort of what I was talking about with the chronic fight or flight. They're always paying attention to their surroundings, and because of that, it's mentally and physically exhausting them.
Right, and with the hypervigilance, we understand that the adrenal glands, which are on top of your kidneys, produce a substance called cortisol, which invokes the fight or flight syndrome. It increases your blood pressure. It gets your heart beating. It draws on the adrenaline. It gets you ready to go. However, when these folks are in a state of hypervigilance, Sarah, this cortisol, this fight or flight syndrome is always on. There's no off. And what happens to a person like that, Jill, when they're in this type of that type of cycle, yo-yo?
Well, they're either in that state of hypervigilance or they're just exhausted, but they can't function normally because they're going back and forth between the two.
Sure, and it causes a lot of physical ailments too, gastrointestinal problems, perhaps some heart issues, drastically lowered immune system. When things aren't right upstairs, things are generally not right in your body. And when things are not right in your body, things are not generally right upstairs. So, what type of medications do people generally go on, Sarah? Jill, excuse me.
SSRIs, including Zoloft and Paxil.
Okay, and here at Sinclair, what we do, we also look at what we would call a differential diagnosis. What are some other factors which could disguise themselves as presenting as PTSD?
Addictions, traumatic brain injuries, anxiety disorders, and depression, adjustment disorders.
Sure, absolutely. So what we generally do with a person, Sarah, is get their whole and complete story. Okay, everyone has a story, and it needs to be told. And traumatic brain injury is associated with PTSD. You were telling me what percentage of the time, Joe?
Almost half.
Yes. So those are things that we want to roll out. We want here at Sinclair, we like to take a holistic view of the individual and examine the mind, body, and spirit. Look at the intensity, the frequency, the duration of these symptoms, and generally, the diagnostic criteria is that these folks have to be experiencing these symptoms for 3 months. Anything under 1 month, we begin to look at other symptoms. And here at Sinclair, so we've perhaps you've self-diagnosed yourself with a PTSD, which I do not suggest. So what do we do? It's have you ever heard the saying, when life gives you lemons, make lemonade? You ever heard that, Sarah? Has anyone ever given you the lemons?
No.
Has anyone ever given you the sugar or the water or the instructions?
No.
Or the pitcher to put it in?
No.
They just pat you on the shoulder and walk away. However, here at Sinclair, we offer empirically driven methods to deal with PTSD. And one of the methods we deal with here at Sinclair is the modality of dialectical behavioral therapy. One of the things we do is to help people to learn to, number one, is distress tolerance, and that would be radical acceptance. And radical acceptance means that that's the way that things are right now. And to learn to be non-judgmental, it's neither good nor bad. That's the way the situation is. Did you ever get a flat tire, Jill? Ever get on the road and get a flat tire?
Actually, haven't.
You haven't. How about you, Sarah?
No.
Never had a flat tire. Well, I certainly have. And when you have that flat tire on the road, you can look at it either one of two ways. Either the tire is always going to be flat, or radically accepting that the tire is flat, then we do something about it. Okay? We help people to identify and label distressing emotions without responding to them. Okay? And emotions love each other. Emotions love emotions. Generally, emotions build on each other. They just love to do that. So what we work on is skills to deal with emotional responses, coping skills to learn how to handle them. Okay? At Sinclair, we suggest that you do not push something away, because let's say, Joe, when somebody generally in life, when somebody pushes you, what happens? What do we normally do?
If somebody physically pushes you,
yeah.
you push back.
You push back, right. So when we have these intrusive thoughts, which leads to all these actions and behaviors, which causes some distress and dysfunction in our lives, we address them. We don't push them back. Okay? You push something back, it pushes harder, and then you've got a full-blown battle on your hands. So what we learn how to do is to accept that these things are happening, recognize them, attempt to be non-judgmental, and we deal with them. Instead of pushing them away, we attempt to let them go. Okay? So one of the skills that we use here is called a Teflon Mine. And if we view these thoughts, these flashbacks, all these things that are occurring, anyone in their life, as eggs. Okay? And you have a pan. The egg, the thoughts, the ideas, the cues, whatever, keep falling into that pan. These eggs that are ideas. And pretty soon you have a pot full of pretty messy stuff. And soon it begins to stink. It's pretty lousy. So what we do with DBT is help people learn these skills, so when those thoughts of distressing things come, we turn that pan slightly, and we learn how to slide it off. Words are easy to say. What it takes is action and effort in your life, and we begin by making small changes. Small changes lead to big ones. Small identifiable goals that people can build on. Okay? Are we going to try to move the mountain of stones all at once, or can we work on one rock? Can you pick up a mountain of stones?
No, I can't.
Well, can you pick up a rock?
Yes, I can.
Okay, so that's what we try to do. And here at Sinclair, we try to teach individuals. We try to enhance their lives in factors such as, number one, treating physical illness. Balance your eating. Nutrition is such an important part of our body because food does affect mood. We deal much with sleep. Okay, there are many people who have disturbed sleep patterns. You ever have disturbed sleep patterns, Jill?
Sometimes.
Yeah. How about you, Sarah?
Yeah.
Sure. And sleep is so integral to any recovery from anything, and every individual on earth is in recovery from something. Sleep is when our mind heals, and sleep is when our body heals. We attempt to balance stress and building mastery over these. At Sinclair, we attempt to give you a tool belt and allow you the opportunity to get new tools and to keep them sharp. So we're going to be closing out today, and should you have any questions or concerns, please address them with us.
Okay. To continue the conversation, please like us on Facebook, plus us on Google+, or follow us on Twitter under St. Life, and keep an eye on any of these for our next live recording, Mondays around noon, to ask your own questions. You can also find this and other grand rounds on youtube.com/StClairVideo and find audio versions on iTunes, Stitcher, Spreaker, and iHeartRadio. And please visit www.stclair.com for more about us and other articles on our great blog.
And as we close, we ask you please to be good to yourself, and may the sun shine upon you as it's shining in Pennsylvania.